And it's time to get started on our program. Thank you. My name is Chris, and I'll be your presenter today. We're going to talk about Medicaid compliance once again, and the 8 elements that are associated with our compliance plan. I thank you for your time. There are a couple of handouts that I've attached that you can download. At the end of the program, we'll ask you to print and sign the document. It's the annual Code of Conduct, and we'll ask you to send it to your department head, who will witness it and send it off to Dawn so that we can check off that you indeed attended the program. Also, if there is anybody from Maine Pediatrics on the line here, thank you for joining us as well. And same thing for you. There's a document for you to sign and give to Jackie to witness. Okay, so let's get started and move along here. If you do have any questions, there is a chat. There is a chat area where you can put a question in the chat. Okay, so why is this program mandatory? Well, it's the law. Bottom line is the law. We're expected to follow the law, and MHA is committed to doing that. So the reason why it is a mandatory program in the law is because it's all about protecting the finite resources. So taxpayers pay money into the federal and state governments for various health programs, and because we as MHA accept those payments for the services that we render for many people, we're expected that we can show that we're using those funds appropriately and that we're receiving those funds appropriately. And your part in this is that you're expected to sign off on the Code of Conduct because it does detail MHA's expectation for you on behalf of the law and just good business practices. So the goals for today's meeting, very, very simply, for those that have been around for a while, you've heard me do this program before. I do it personally because I believe it is the right thing to do, that you hear consistently from the compliance officer as to why we're obliged to do this. And so we're going to review, refamiliarize all of us on our obligations. We're going to talk about fraud, waste, and abuse again, remind everybody about that. And then hopefully at the end of it, you'll just all be on the same page that it is our role to protect these finite resources for healthcare services. So we talk about it again because every year there are billions of dollars that are improperly spent. Fraud, waste, and abuse is around. It does affect everyone, including us. And I guess our goal is to be proactive where we can and to help us detect, correct, or prevent fraud, waste, and abuse. And it is our responsibility, both as a company and as individuals. Are we compliant? Of course, our intent is to be completely compliant. And what we have to realize is that all the activities that we do are subject to scrutiny retroactively. The payers have the benefit, and the government has the benefit of looking at us behind the scenes and tracking what we're doing. And then if they sense that there's a problem, they can, of course, come back and talk to us about it. So here's an example from October. I know it's small to read. I'll just summarize it. On the left is the final letter that this nurse practitioner received in Buffalo from the New York State Fraud, Waste, and Abuse. Apparently, they took issue with her receiving a check, her company receiving a check for $21,000 for meaningful use, and for whatever reason decided it needed to be returned, which is up here. The findings suggest that she has to return this money that was paid to her this past year. If you're interested, here's the website. It's a public website that you can go to, and that's where I found it. And just as a reminder, the OMIG here, OMIG is the New York State Inspector General Office. The federal version of that is the OIG. And oftentimes, if there is an issue with one, they do talk to each other from time to time, and they let the other one know who could also do an investigation as well. What you're looking over here at the right, where these brown bars are, this website will give you a month-by-month report of all the activities that they performed, and that's where I found this one. I just looked for September, and I looked for under physicians, and these are the ones that came up. Most of these are from New York City and downstate, but nonetheless, there was one from Buffalo. So it is real time, but this is the format in which New York State will ask for money. And keep in mind that this is a 2021 letter, but the payment was made a few years earlier. Okay, so this is a review. What's fraud? Fraud's all about willful and knowingly asking for funds for which you were not intended to receive. So examples of fraud: knowingly billing for services that were not furnished, billing more than once for the same service, misrepresenting a diagnosis to justify payment. And that one's very relevant because I'm sure from time to time, each of you have been asked to change a diagnosis code in order to justify a payment by the health insurance. Well, keep in mind that if we do that willingly, knowingly, we could open ourselves up to a fraudulent situation. Falsifying identity of a provider to obtain payment, billing for appointments that patients fail to keep. As you know, for commercial payments or patients, we can bill a no-show fee. But for New York State, for Medicaid patients, we are not allowed to bill no-show fees. Bottom line, knowingly altering claim forms for the purpose of getting higher payment. Basically doing something knowingly in order to solicit more payments when we know that it's not proper to do that. That, by its strict definition, is what fraud's all about. When you talk about waste is really just overusing services. Overusing services, not necessarily to get more money, but nonetheless, in the opinion of the regulators, services that are done above and beyond what would be typical for a scope of service can be construed as a waste. It's not generally considered to be negligent or criminally negligent, but rather just a misuse of resources. So examples: excessive office visits, prescribing more meds than necessary for a particular condition, ordering more labs than necessary, not billing in accordance. Basically, it's doing things that are above and beyond what would typically be the norm for a particular situation. And finally, excuse me, abuse. Abuse is sort of the catchment at the end where everything else falls into. That's things, any actions that may directly or indirectly cause unnecessary costs to the program. Abuse involves payment for items when it's not legal. There's no legal entitlement, but not that you knew. The provider has not knowingly or intentionally misrepresented the facts. Basically, it's making mistakes as well can be considered abuse. If we inadvertently bill a wrong diagnosis code with a given CPT, and we do it for a while, that could be considered abuse if it's found after the fact. For the bottom line is ignorance is not bliss when it comes to what the regulators and the payers expect. So here's some examples: billing for unnecessary medical services. Again, oftentimes, because payers have different opinions about what should be payable, what may be payable for one payer may not be payable for another. And certainly when it comes to Medicaid, what they think is proper payment for services. Misusing codes or unbundling codes. That's about breaking apart codes in order to bill multiple single codes versus one group code. Improper use of coding modifiers. That's a very real situation right now. MHA is in the process of being audited by one small payer because they don't like the fact that we're using this particular modifier with this particular well visit. So we're in the process of providing information. So far, all the feedback has been positive that we've been doing it appropriately, but nonetheless, we have to go through the process of complying with the audit and the request for records. And lastly, lack of medical record documentation. The old adage, if it wasn't documented, it wasn't done. And we've heard that for as long as I've been around. That's been the case. So certainly if the payers or the regulators feel that not enough documentation was supported to support the services was put in the note, then they could allege that there was an abuse of a particular set of claims. So again, one more time, to ad nauseum, what's the difference? About the big one for fraud is that it's alleged knowledge and intent. And when someone accuses us of fraud, of course, we take it very seriously. But from a legal standpoint, it's about whether or not we knowingly did something wrong and we intended to take advantage of the situation. So what you see down here is a laundry list of the various punishments that could occur, ranging from rejection of a claim to monetary penalties to civil and criminal lawsuits. They take your money and they put you in jail. And in some cases, the loss of provider license, which of course damages your ability to have livelihood as well. So any one of those things can happen depending on the seriousness of the situation. And I think it's just important for us to realize that that range does exist relative to what we do every single day. So what's your role in this? Your role is to help prevent, detect, report fraud, waste, and abuse, as well as non-compliance. Number one is take it personally, to be sure that you're doing your best to comply with all these requirements that are thrust upon us. Two is that if you sense it or you have a question about a compliance issue or fraud, waste, and abuse concern, that you talk to somebody about it. Don't feel that you need to have to keep it in or hide it or be concerned about it. You should at least ask the question. And third, we're going to ask you once again at the end to sign that code of conduct so that it's a record that you participated in the program and then that you do take all this serious. So what does New York State Medicaid expect from us? They expect us to do this annual certification and excuse me, and then to follow what's known as the 8 Elements program. The good news with New York State is they did provide a template that would aid us towards gaining compliance with these rules. It's referred to as the 8 Elements. So we're going to start right with element 1. So they take a sip. And proceed number 8. I'm going to go through these at pace. Once again, if you have any questions, feel free to drop me a note on the chat. So element number 1 is very simply, we have to have written policies and procedures. And what you're seeing in front of you is that there is a policy that we will comply. That's number 1 policy, and that we will, and this goes beyond just the fact that it's a law. This is good business practice. We want you all to believe that MHA's role and the division's goals are to be as compliant as we possibly can be. And our intent is to be fully compliant with what we're required to do. And we also want our patients to know that we're going to be good stewards of this finite resource that's paid for by them and all of us through our taxes. It's our policy to exercise due diligence to prevent and detect criminal conduct. And we really want our culture to promote that. We do have a zero tolerance for proper, and all this is baked into our policy and procedure. And if there is an issue with the expectation is that you'll work with us to basically correct the issue either through retraining or another way. We do have audience participation questions, and what you're seeing here is the first one, and I'm going to actually start a poll. I'm going to ask you to respond to it, and the first question is, our compliance officer is the managing partner of our division, it's Stefan Diggs, it's Chris Terabasi, or it's Jackie Nelson. So if you wouldn't mind just entering your response on your keyboard, I can see what you're responding. And look at that, 100%. And so I'll close the poll. And yes, depending on your office, Chris Terabasi is the compliance officer for Medical Health Associates. And if you're with Maine Peds, Jackie Nelson is your compliance officer there. So thank you for participating there. Number 2, the policy requires us to identify those who are specifically and personally responsible for maintaining compliance. And in the case of our plan, it is the compliance officer who works with the compliance committee, and there's a physician representative from each division who's on the compliance committee. And then there's also what's known as the certifying officer, which is the person to whom the compliance officer reports. And in our case, the certifying officer for Medical Health Associates is Dr. Colleen Matamore at Western Peds, and for Maine Peds, it is Dr. Emily Ferdan. So number 3, training and education. That's why we're here. We're doing this program as part of our annual training and education program. And it's our effort to train everybody. And basically, we're going to use any means necessary to get the message across. All newly hired employees will see this particular web presentation and they have to sign a code of conduct. So they come right into the organization knowing that there are expectations for compliance. And then, of course, if there are any questions, I'll always say questions, ask the question. I may not know the answer immediately, but certainly we'll do our best to get back to you as soon as we possibly can. Element number 4 is communication and reporting. An open door policy remains with the compliance officer and the committee. And if, again, within your division, if you have a question, I do encourage you to reach out to your compliance committee representative. And our goal is to have effective lines of communication. It can be an email, it can be a written memo, it can be face-to-face communication. If there's an issue, bring it up and we'll talk about it. Again, we'll do our best if we do identify or come across a compliance issue, we will attempt, or our goal will be to have the process be confidential, but we can't guarantee it depending on how the process goes. At some point, if it gets very deep, the identity of the complaint may come out. We don't know, but nonetheless, don't let that be a deterrent for you bringing it up in the first place. Number 4, oh, well, look, before we go forward, there's another audience participation question. So let's move on to that one. And the next question is, which compliance mishap could be implicated by defensive medicine Fraud, waste, abuse, or what is defensive medicine, you may ask? Well, defensive medicine, just while you're thinking about the answer, is a behavior. It's a behavior that is understood to occur in those cases where a provider feels it's necessary to do something to prevent what could be a medical malpractice situation. It really doesn't really pertain or is implicated as much in the pediatric world, but certainly in certain specialties, and I won't pick on them, but the ER, orthopedics, neurosurgery, those kind of very high risk or more risk specialties, it's been known to occur. Radiology, the same. Excuse me. And yes, you are correct. Thank you for your vote. It is waste. It's considered to be wasteful to the market basket, even though it truly is a real behavior that is out there. Thank you for that. Okay, so we're moving on to number 5. Number 5 is disciplinary policies and procedures. Any policy worth its salt has to have discipline built into it. And the expectation from the regulators is that we will have teeth in our discipline in our policy. And sure enough, the OMIG, as I mentioned earlier, and the OIG very blatantly say that if we have a policy and we don't follow it, we're just as guilty as the person who perhaps is violating the law. So we're obliged to have teeth, regardless of the level at which the problem occurred. We're expected to be able to discipline. Now, by definition, discipline can be something as simple as retraining, or worst case is that we have to file a complaint with a police organization or with the government. In my experience, the most common things that have been considered to be compliance issues were a result of a mistake or misunderstanding, and were readily fixable by virtue of retraining. We also have to identify what are known as risk areas. And risk areas are those areas that we think we are more likely to have issues. And the compliance committee and myself have come up with the following items that we believe would be considered risk areas. Billing for services not documented, lack of integrity in computer systems. So in our case today, that's ment. And that ties in also with, on the security side, when we talk about HIPAA in January, making sure that our ment system is integral and is functional. Confidential of information and records, again, ties in with HIPAA, which of course is very important for us. Failure to use properly use modifiers. As I mentioned earlier, that's a real-time situation going on with medical health associates where we have to provide documentation to the payer in order to justify why we used a particular modifier. Once again, knock on wood, so far, we are 100% compliant with the reasons why we use the modifier. And lastly, discounts and professional courtesy. And what that's referring to is we cannot identify individuals who are eligible for discounts. Basically, that flies in the face of what the regulators are wanting us to do. We are prohibited from hiring people who have been convicted of an offense involving healthcare. And you may not be aware of this, but it's true. All new employees are subject to a background check. And actually, each one of us as employees of medical health associates, each month, our names are run across a register with the federal government that does background checks on us to be sure that we have not run afoul with the healthcare law. So that's something that we're required to do. We do it behind the scenes. It's managed at the MHA offices, and we do comply in that regard. Element number 7, monitoring and auditing. We are required to at least once a year do some sort of internal look, introspective adjudication of our own situation to see if we can uncover anything that may be of concern or an issue. We can do it internally, or we can recruit an outside firm. And we every year the compliance officer and the compliance committee go through a program. This year we selected 2 of the assessments, ASQ and MCHAT, and are doing a look back to see how well we are doing with 3 key components. 1, are we coding it correctly? 2, are we putting in the proper diagnosis? And 3, do we have the proper documentation? And the results were not surprisingly not good. Where we did find that there are situations where we are not doing all 3 of those things as religiously as we should be. But the good news is that's part of the reason why we're going through this consolidation program that's excuse me, happening this quarter. And our plan, and we've done some education since we ran this program. We actually did the sample last spring, and we're working on it now. Excuse me. But we're going to run the same study a year from now. And the goal is that those same 3 parameters will be reevaluated for those tests. And we're believing that we'll be compliant or more compliant with regards to results once we do the implementation of the consolidated database. So once again, very willing, compliant to do an introspective look to see how we're doing. Last but not least, element number 8, and this is the reason why I encourage you, if you do have a question, to come forward, because MHA is obliged to not retaliate or to discipline anybody who has a question or raises an issue with regards to compliance. And I just can't believe that someone would retaliate, but nonetheless, we're going to say it anyways. And certainly I want you to know that you are free to come to me on the open door policy, ask the question, and we'll do our best to investigate it as quickly as possible. And I think we have one more audience participation question. Oh boy, isn't this exciting. So once again, why is this session mandatory? Because Kathy says it is, because Chris says it is, because protecting New York State Medicaid program is important, because protecting my providers and myself is important. So if you want to take a shot at that one, well, that's a good answer. And the truth is, any one of them are true. So Kathy, who's Kathy, you may ask? Our governor. Chris. Kathy Harrell. Chris is me. And of course, protecting New York State and protecting our practice and myself is important. So we'll end that poll. So in closing, the Cod of Conduct, we have a fish document, I guess. The Code of Conduct is a document we'll ask you to print down, sign it, write your name, print your name too, so we know it's you. Sign it, give it to your immediate supervisor for witnessing, and she'll get it to Ms. Dawn at MHA so that we can check you off as being an attendee to this program. And I do see a chat question. Thank you. B. Okay, Mary, I'm not sure what the rest of that is. Oh, B, you answered. Very good. Again, if you have any questions after the program, feel free to drop me a note and we'll get back to you. Aside from that, we are done with the program. I really thank you for your time and I hope you have a good day. Goodbye.